First of all, I thank Dr. Kondal Rao. It is indeed my great pleasure to be part of our CSI and after forming the new Telangana state. So it's impossible to cover everything. However, I will just highlight certain things. These are my some of the disclosures that inventor of this and Konar MF device, and also I am part of the neonatal stent kit. What is known in heart failure? We all practice for the past 3-4 decades using the diuretics, AC inhibitors and beta blockers in the last 2 decades. There are certain things which we don't know and which are new, like cardiac resynchronization therapy, combination of medications and some of the surgical advancements. So I am going to highlight some of those. What is not known, still there are a lot of uncertainty in some of the things. So this is one of the case scenario of 21 years, 28 weeks gestation referred with the hydrops, lot of family fetal hydrops and deaths. So we found that there is a large pericardial effusion and you can see the arteries which are calcified. So we have to remove the fetal in utero pericardiocentesis, and then we sent the whole exome sequencing which showed that a malignant kind of a genetic disorder called fetal arterial calcification syndrome. These are some of the things which we really don't know, and we need to work on all these aspects. The heart failure in children are essentially due to structural heart diseases, 80% of the situation. So if you treat them, most of the conditions will be cured and they do very well. Some of the conditions where there are no structural problems, it's a genetic, primarily we need to address that genetic level, molecular level. In the present era, we all classify the heart failure in children using the RAS classification. It is a modified WHO classification for the sake of easy understanding and treatment modalities. If you look at the viral myocarditis or DCM in children, if you look at this graph, this is prior to the commencement of the conventional mode of treatment, beta blockers and AC inhibitors. From 2000 onwards, we are very aggressive, essentially because of the extrapolation of data from the adults. You can see this is the child when I was at Care Hospital, a big heart, and now it became very well using the AC inhibitors and beta blockers. What influenced the clinical practice? The advancement of pharmacotherapy, cardiac resynchronization, some of the heart failures, VADs and cardiac genetics. So still in our part of the country, especially in Nalgonda, Karimnagar and Mehboob-nagar, beriberi is one of the commonest problem. You can see that every week I see one baby. If you look at here, you can see the gross cardiomegaly and pulmonary hypertension, ventricular dysfunction. We just take blood sample, give thiamine injection and repeat echo in 2 hours a time. We don't give any diuretics, anything. You can see this is immediately after 2 hours a time, and thiamine levels will come extremely low both in mother and baby, suggests that it is a beriberi. So you all know the mechanisms, so go back to the biochemistry and you will understand the pyruvate Krebs cycle mechanisms where it is. It is very common in our part of the field. So in principles of manage, diuretics, vasodilators and inotropes play a major role. This familiar diagram you all know, a tired donkey is predominantly, if you take the preload with the diuretics or improve the contractility or reduce the slope with the vasodilator, going to improve it very well. So diuretics play a major role still in children, but addition of thyroid diuretics during long-term management is very crucial to prevent sodium loss and other things. But present concept, we should avoid chronic diuretic therapy because it causes a cachexia and serious electrolyte disturbance in these children and they develop malnutrition. So management using the acute inotropes during acute stage is very crucial, and we should decide what kind of management. A traditional digoxin, see, look at the beautiful flowers. Traditional digoxin is no more recommended unless there is a significant ventricular dysfunction. So we don't regularly use it, but it's an adjuvant therapy in most of the situation. Whereas phosphodiesterase inhibitors like milrinone, we use extensively now in the acute setting to commence the vasodilator therapy. You can look at this the arterial trace here which is constricted and which becomes dilates after few hours of the milrinone therapy. But we should be very careful in choosing the patient. When there is hypotension already, it may be sometimes dangerous. So ACE inhibitors and ARBs play a major role. We actually got a lot of data from the adults and extrapolated from the adults, and we should be very careful in using especially captopril, enalapril in less than 4 months of age because of the renal failure and other things. Beta blockers, there are a lot of trials, but this trial is Robert Shady. I met him, he is one of the editor of Moss and Adams, and do very well. If you look at this slide, the beta blocker response is very great whenever there is a tachycardia, severe dysfunction, and they respond to the diuretics. Once you give diuretics for 48 hours, probably that is the time you can do it. This is a 27 days neonate with refractory heart failure, large VST, you can see that, and failed extubation. We put a Konar MF86 device and still big heart, baby did not improve. So we have to start carvedilol and enhance it the dose, and baby improved very well, tremendous response with the carvedilol in spite after putting the device. That indicates that there is a diastolic dysfunction, even you close the structural defect. So this is the panorama trial. We also actually embarked on this valsartan and sacubitril combination now. For the first 6 months, we treat these babies with children about 2 years. We generally prefer to give that, and we see very good response. At the same time, ivabradine is one of the medication which is proved, and the trial showed that good results with that, and we add to this medication, so you will see very good response. Levosimendan is sometimes wonderful drug, but you have to choose the particular patient. It is not the first line medication. As soon as you get the heart failure in DCM or myocarditis, first give diuretics, then give inotropic, then probably after 48 hours is the ideal time to commence the levosimendan. So this is one of the case. You can see 4 years old boy, you can see the blood cyst in that because of the LV dysfunction, and we started inotropes, anticoagulants, and also levosimendan, and tremendous improvement in terms of ejection fraction and heart failure in this particular child. So step 1, diuretics, ACE inhibitors, beta blockers, and finally aldosterone is going to be important thing. Cardiac synchronization therapy, lot of published data. When we are at care and with Narasimhan sir, we could do couple of patients in that. But this is one of the case. You can see structural heart problem, CTJ with ventricular dysfunction. We have to put his bundle pacing here, improved tremendously, and the cardiac size also in the last follow-up has come down. So now his bundle pacing and left bundle pacing is coming more often, and a lot of people including Dr. Shanmuga Sundaram is doing it. So this is one of the heart failure patient recently we saw and did not improve. Then we have to send this patient to Chennai for the mitral valve repair because they went there for the cardiac transplantation. So after that she improved very well. Now she is in class 2 symptomatic stage. Dietmar Shah, he is from Gießen, very close to me, and we shared lot of data. This is one of the interesting hypotheses. Whenever there is a gross dilation with a normal right ventricle, you put a PA band, there will be septal shift and improve the ejection fraction. So they demonstrated quite good number of patients, and you dilate the pulmonary artery banding after 2 to 3 years. Lot of heart failure devices came. We have very less knowledge in this, and we had one opportunity to use the ECMO, and one of the case we sent for the LVAD as a BTT in one of the grown-up kid. Cardiac transplantation, I got the data from Ganapati and Dr. Bala. They have done pediatric transplantation, 103 cases, of which 53 were dilated cardiomyopathy. I will take 1 more minute because there was an issue. So 1 month follow-up 90% and 4 years follow-up showed 74% of survival. These are the patients who are doing very well after the transplantation. So severe LVOTO, sometimes we should see that we should not abruptly send them for transplantation. This is one of the patients listed for transplant, and you can see that the membrane was removed and ventricular function improved excellently. So This is the roadmap for heart failure in management of children. First you do the rescue phase, then escalation phase, then stabilization, then study phase. That's going to be very, very important. Most important thing is treatable conditions like a calcium deficiency and tachycardia cardiomyopathy should be kept in mind and should be treated. These are some of the treatable causes. We'll remove it. And genetic clinic we started for the past 2 years, and these are our cardiomyopathy patients who are positive for the genetic. Most of the times it's a sarcomere and other problems came, and we counseled the family, and subsequently they went for the IVF using the some donor egg and other things based on the situation. This is one of the patient with the pompous and ventricular dysfunction. To summarize, several recent advances changed the clinical practice of patients with the heart failure, especially in children, and now the data showed more than 60% are doing extremely well. Most of the data we got from the extrapolation of the adult data, which is useful to conduct the RCT trials in children. Acute and medium-term follow-up data appears really encouraging at this point of time. Thank you very much for your kind attention.
Sir, excellent presentation. The experience regarding the evaporating funny channel blocker in the children heart failure.
It is very good medication, but as a first line, we don't recommend it. Reason is, after giving diuretic therapy and inotropes, you commence the AC inhibitors and start beta blockers. Those who don't respond to the beta blockers, if you add ivabradine, they do very well. If already beta blocker response is there, if you start ivabradine, the bradycardia is going to be very, very significant. There is one paper actually in ICU setting, they started ivabradine even in post-operative setting, it did very well. So I don't want to generalize the statement, but a subgroup of patients, they do very well with ivabradine, otherwise they don't do very well. So it is not 100% it is going to be there. Unresponsiveness to the beta blocker, then add ivabradine, they do very well.